Well, thank you, and thank you to EUREGHA for inviting me to join this very interesting session. And as it has been mentioned, I will try to deal with, for me, the need to interact between the national level, the European level, and the regional level in order to improve cancer control. And I will try to show some ideas, some examples from the Catalan perspective and the Spanish and the European perspective. This is the outline of my presentation. I will briefly introduce the Catalan and the Spanish healthcare system and the interaction. What we have learned from the experience in the last 10 years in different joint actions involving national, regional, and scientific societies and patient groups in the experience of the joint actions, and the challenges that we have now as we see from our Catalan perspective, and some concluding comments. So the Catalan and Spanish healthcare system, it's based on national health system model, decentralized, and in Spain we have strong decentralization in different regions, in the 17 regions in Spain, but we share the catalog of services, so in theory all the Spanish citizens should receive the same level of care and drugs that should be approved in a consortia between the regions and the Ministry of Health. And we have also a national strategy on cancer developed by the regions, the Ministry of Health, the scientific societies, and patient representative. And I am also, in addition to be the director of the cancer plan, the Catalan region, I'm also the scientific coordinator of the Spanish strategy against cancer. And we have regional strategies. The Catalonia was the first. 20 years ago, we began to implement our strategy. So some specific aspects about Catalonia. We have also health regions within the Catalonia, as it has been mentioned in the presentation of my talk. There are a lot of variation in clinical practice and variation in levels of resources within nations or within states, but also within regions. So this is also that we need to take into account. We have several reference hospitals at each region with medical oncology, radiation oncology, clinical hematology, and palliative care. We have a model of the cancer care based on the multidisciplinary teams, as it has been mentioned before in the previous speaker about the Puglia. We have designated reference hospitals for complex cancer procedures, for rare tumors, and now, since 1 year that we began our program on precision oncology, for the precision oncology reference centers to deal with all the tests that we are managing with tumor panels for different levels, so for solid tumors, for hematology, for pediatric oncology, and for germinal tumors and hereditary cancers. So there is an annual contract between the Catalan Health Service and the hospitals with periodic evaluation of the quality of cancer care. And we are 7.5 million inhabitants and 64 hospitals. So what's the point regarding the regions? So from my perspective, it's obvious that the regions obviously offer proximity, so better capacity to identify local needs, and also the better capacity to identify the local resources beyond the healthcare, the social resources and all the resources that are associated with a good cancer care. Also, I think it's important if we want to implement our policy according to the needs and the perceived needs of the populations, we need a negotiation that is better carried out at regional level or at local level than at national level. But also, we should also recognize that there is a risk of policy interventions influenced by local interests with hidden agendas. So this is maybe, I think it's also possible at European level with the lobbies, at national level, but also at regional or local level. So I think I strongly support the interaction between European, national, and regional levels in order to provide good planning of cancer care. So I think the objectives are very similar, are very general at each level, but it should be applied. So context matters. because there are differences in the organization of the delivery of cancer care and its relationship with the healthcare system, the global healthcare system. There is also difference in the epidemiological situation, difference in incidence, difference in survival, difference in mortality. There is also a different policy involvement, and in Spain, for instance, we have very strongly different regional perspectives in the policy priority for cancer care, also priority for resource allocation. Also, there is the different roles of public and patients in cancer policy making. For instance, in our region, we have involved in our advisory board of the cancer plan, we have since the beginning patients and scientific societies. And also we have, I think, a capacity to innovating by adapting to the regional needs. And this allows a lot of benchmarking that we can learn from each other how we deal with local and regional aspects of cancer plan. So the other thing is that we should recognize that we have learned a lot from the European perspective on cancer policy. And we have involved since the beginning, I think 12 years ago, on IPAC, CANCON, the Joint Action on Rare Cancers, and the Innovation Partnership Action Against Cancer. And I would like just to highlight three of the main points that we have learned from the European perspective and we have to implement at national, but specifically at regional level in our region. For instance, the issue of rare cancers and a specific target for cancer organization and cancer policy. No, for instance, we have a strong centralization of pediatric cancer care as a learning process and a discussion with the healthcare providers in order to improve the quality of our pediatric cancer care. And I must say that according to our assessment of the survival of our patients, we are quite successful in this approach. We have also learned about the survivorship care, no? That we have tried to apply different approaches by tumor site, by different hospitals and different regions, because it's our perspective that the survivorship care, it's different in rural areas and than in, for instance, the metropolitan area of Barcelona. No? That it's very different, the relationship between the patients and the hospitals and the primary healthcare physicians and the hospitals. But there are shared principles that we try to apply from the EU policy. For instance, the prominent role of primary healthcare, that it's something that we need to implement and to involve primary healthcare, which is really difficult now after COVID, because it is, I think, one of the major changes at least in our situation, is the difficulties suffered by the primary healthcare in managing these COVID patients. The risk stratification, the inclusion of psychosocial aspects like mental well-being, and also something that for us it's really a challenge because it's beyond the healthcare sector, which is the social aspects. You know? For instance, how to deal with the return to work for our patients, which is something that it's beyond our actions, but I think it's something that we need to think how to deal with, the right to forget, the support to caregivers. These are challenges that we learn from other countries, and I think we need to improve. But also we have been involved in cancer policy, and we have contributed to the cancer policy developed in these joint actions. For instance, we developed a consensus with European scientific societies and cancer plans and patient organizations on defining multidisciplinary cancer care 10 years ago. We developed and we tried to implement the concept of neglected cancers, which was suggested by the European Commission. It's a quite controversial concept. Essentially, the criteria is cancers with lower than 33% survival, 5-year survival, which is a criteria. Clearly, all of us share the criteria that pancreatic cancer is the best cancer for considering neglected cancers. Now there is other concept that it's poor prognosis cancers, but I think it's important, this kind of application and the analysis of the cancer plans criteria for rare cancers. All of these we have been working and coordinating in, and we have published several papers regarding that, like the Bratislava statement about how to improve pancreatic cancer care. Also the analysis of different cancer plans in order to improve the pediatric cancer care, and also the policy statement on multidisciplinary cancer care that also we published and we support, and it has been included in the European strategy about cancer. So there is this kind of interaction that it's important for us, and I think it's relevant to have this perspective at the different levels, but also I think our work at regional cancer care, it's how to implement these principles. What are our challenges and what we plan to do in the coming years? So first, consolidate the model of cancer care based on multidisciplinary care with evaluation of clinical outcomes at hospital level. We have been working in the last 6 years on that, based on a combination of specific audits with real-world data. And I think I must say that it has been a very interesting interaction with the hospitals. Some kinds good interaction, some kinds more difficult interaction with the outcomes were not so good. So this is something that it's important for us to keep this perspective on the relevance of clinical outcomes. Second is designated reference hospitals for complex procedures with catchment area with 0.5 and 1.5 million inhabitants and rare cancers. I must say that to find the right balance between centralization and decentralization for usual therapies is one of the most challenging policies. So it's a lot of discussion with professionals, with managers, but also with the measures of the cities and also the policy makers at regional level. So it's something that we need to find the right balance, and it's not just a matter of applying some big criteria, it's also to take into account the territory, the distance, the resources, and other things. Also the adoption of innovations like precision oncology. We started the program almost 1.5 years ago, and now we have more than 10,000 panel tumors analyzed. We have been an explosive starting process of this program. I think the challenge is to define a model of provision of survivorship care considering local needs and resources, and it's something that we need to do. And like here in Italy, we are thinking about a pilot on lung cancer screening and reorganizing the cancer opportunistic screening for prostate cancer, because about 80% of our population has undertaken PSA. So the issue is how to reorganize this in a more rational way than the opportunistic screening, but it's something that it's a challenge because of the diffusion of the prostate cancer screening. And also I would just make a specific comment regarding the new joint action, because it's a joint action about the comprehensive cancer care, comprehensive cancer centers, how to deal with these issues. And I must say that the European Beating Cancer Plan includes this kind of statement that by the 2030, 90% of the cancer patients should receive treatment in a CCC. So, for instance, in Spain, we don't have CCCs like as for instance you have in Italy with these institutes like the Bari Institute. But we have reference hospitals with high number of patients, good quality, scientific research and output. So we need to reorganize cancer care to build CCC within tertiary hospitals with autonomy of leadership and management within these hospitals. So following the models that has been developed in Sweden, in Germany, or in France, or in other places. So but it's a challenge for us. And it's a challenge thanks to the European approach, and our interpretation of this approach is the relevance of supporting specialization in cancer care and the autonomy of the management of the cancer care within the tertiary hospitals in the framework of a CCC. So I think for us will be really a challenge, and I think it's important to think about this and to follow and this new joint action about that. Because for us, the major point is that the message of the European Union is that the quality of cancer care, it's strongly associated with how we organize cancer care, how we organize the delivery of cancer care in the territory. So, as a concluding comments, priorities should be adapted in cancer care, should be adapted at regional and local context. Benchmarking, it's always feasible between regions if the implementation is properly evaluated, and this is important. Regional experiences or policy targets could be adapted at national, at European level, and collaborative experiences in the joint actions are an excellent example. And the mutual interaction in defining cancer control priorities at each level, European, national, and regional, it's a requirement, although it takes time and needs a cooperative approach, which is never so easy to develop. But I think this is also a challenge. Thank you very much.